So the topic that I've been given today is novel WBC parameters. So we know that we have come a long way since the era of the first hematology analyzer that was made by Sir Wallace Coulter in 1956. So we've seen many transitions in the journey from multi-part analyzers to 3-part differential counters to 5-part differential counters, and then automated hematology counters with reticulocyte, with automated nucleated RBCs. Some people are giving 6-part, 7-part, and now even multi-part analyzers. So the list is just endless. But broadly, all the new parameters that are available on the modern analyzers are still broadly classified according to the cell lines, that is RBC, WBC, and platelets. So since the topic is on the novel WBC parameters, I'll be covering some interesting new WBC parameters which I feel have got a lot of clinical relevance and a lot of traction in today's diagnosis. So broadly, I'll be covering 3 parameters. First is the immature granulocytes, or what they call as the IMG. So this is nothing but a numerical representation of what we call in the peripheral smear as the shift to left. So the higher the IMG value, we got a biological reference interval for it also, the more is the shift to left. The second is the neutrophil Y, or the new Y. Now this parameter basically depicts the amount of DNA and RNA content in a WBC or a neutrophil, and thus is directly related to the fluorescent signal that the neutrophil is generating. So again, the more immature the cell would be, the higher would be the DNA and RNA content. Is pretty much on the same lines. So both IMG and new Y are pretty much parameters which are by and large used to diagnose bacteremia and septicemia. The third in the line is the high fluorescent cell, or the HFC. So HFC is nothing but what we used to call earlier as the Turk cell or the Downey cell. Some people like to call it the virocyte, transformed lymphocyte. Basically, it is a lymphocyte that is activated by primarily the viral infections, although it can also be seen in certain lymphoproliferative disorders. So we'll be seeing how HFC is helpful, especially in dengue, in both prognosis as well as diagnosis. So before I go further, I will just briefly tell the principle of fluorescence flow cytometry. Because of this, we have been able to now differentiate neutrophil, lymphocytes, and monocyte in the X, Y, and Z axis. So the first is the forward scatter, or the Z or the Z axis, whatever you want to call. So higher is the forward scatter, the bigger is the cell size. So when I say new Z, I'm meaning that I'm talking about the size of the neutrophils. The second is the side scatter, or the granularity, which is depicted by the X axis. When I say new X, I'm meaning the granularity of the neutrophil. This is another parameter which is very useful in MDS, especially the new X is significantly lower in MDS in compared to the normal population. And last is the new Y, which is what we are discussing today. This is basically depictive of the site fluorescence of the cell line. So higher is the site fluorescence, the higher is the RNA and DNA content. The next thing I'm going to show is the SF cube technology. Basically, this is nothing but the 3-dimensional positioning of the different cell lines. If you look at this green area here, this is the area of the lymphocyte. Just above it is the pink area of the monocyte. This sky blue area here is the area of the neutrophil as well as the basophil. This red area here is the area of the eosinophil. Just above the monocyte, these small green dots, this is the area of the HFC, or the high fluorescent cell, or the virocyte, whatever you want to call it. So higher is the scatter density in this area, the more are the HFC. Likewise, this area above the neutrophil, is the area of the immature granulocyte. So if you see a lot of scatter dots in this area, this is the area of the IMG. So first, coming to the immature granulocytes. So the key feature in distinguishing immature and mature stages of leukocyte, we all know, is the MC ratio, chromatin, cytoplasmic quality, the granularity, and we all know the stages of maturation of neutrophil from myeloblast right up to the segmented neutrophils. So in a peripheral smear, what we are likely to see is both the mature neutrophil as well as the band forms. But usually in a normal subject, we would see nothing left of it. But if we see the myelocytes, metamyelocytes, promyelocytes, and even blasts in a peripheral smear, we know that we are looking at either some systemic inflammation and sepsis, or worse, bone marrow infiltration. So usually when we compute IMG or the immature granulocytes or a set analyzer, this includes promyelocytes, myelocytes, and metamyelocytes. However, blasts as well as the band forms are excluded from this count. This is a good prognostic marker to detect both bacterial and infection as well as sepsis. It can be used as an early marker in the diagnosis of sepsis. And the biological reference interval that we have in our lab is 0 to 0.7%. It can vary slightly depending on the answer and the dye that you use. So if you look at a normal patient, this patient has an immature granulocyte count of 0.1%, which is normal. You can see that this is light blue area, here is the neutrophil area. There is hardly any dot in this IMG scatter area. Contrast that to the scattergram of a patient of septicemia. The IMG here is 5.6%, and if you look at this area here, you can see that there are a lot of dots in this IMG area. So the moment you see that there is scatter clustering in the immature granulocyte area, you know that you are looking at a bacteremia stroke septicemia scenario, and if worst off, if it will be a leukemia, then it will all go as single scatter plot and not into two different compacts. Next we have this NUT-Y. So there is something called as the cell population data, or CPD, which provides quantitative information regarding both morphological as well as functional characteristics of the three cell lines, that is neutrophil, lymphocyte, and monocyte. And this CPD allows a more detailed study of the cells and detect various variation and response to stimuli, primarily infections. So as I earlier said, NUT-Y is a parameter which is related to neutrophil fluorescence and is a measure of the cellular DNA and RNA content. And it is also a parameter which can be used to differentiate normal patients from bacteremia and septicemia. So this is the paper that we presented in 2020 in the ISLH. It was meant to be in Melbourne, but it ended up being a virtual ISLH for the reason we all know. So the paper was predicting developing sepsis, CVC, and more. So what we were trying to do here was that we were trying to evaluate all these new novel WBC parameters, NUT-Y, mono-Z, neutrophil lymphocyte ratio, and immature granulocyte, to see whether they can differentiate A, bacteremia from septicemia, and B, also assess whether they can be used as a prognostic marker to predict severity of sepsis. Or they could be used just like procalcitonin, as the procal values reduce, they wean the patient off the antibiotics. Can, some numerical values be used as a surrogate marker to procal in this study? So what we did was we did the serum procalcitonin for all our patients using Mindray chemiluminescent 960i analyzer. All the hematology parameters were done on the hematology analyzer BC 6800 plus. And the blood culture was done for each of the patients enrolled in the study using Bachelor 3D from Biomédio, France. So what we did here was a simple 4-step methodology. All the blood samples, which were 5,000 in number, were run for CBC on BC 6800 plus, just to get the reference interval of these 4 parameters, NUT-Y, mono-Z, immature granulocytes, and neutrophil lymphocyte ratio in healthy subjects. Further, we selected patients of pyrexia who had registered for us for both CBC as well as blood culture, and only those patients were chosen which met at least 2 laboratory criteria of the surviving sepsis guidelines, and procal levels were ascertained for each of these samples using the Mindray CLI analyzer. We did the blood culture for all the subject patients. The culture negative subjects were excluded from the scope of the study. At this stage, we calculated the Uden index for each of these individual parameters, and we tried to maximize the ROC cutoff to get the diagnostic sensitivity and specificity using the MedCal software. So these are some of the results in the normal versus the bacteremia group. As you look in both mono-X and mono-Z, there is not much difference in the mean in the normal and the bacteremia group. But when you look at the NUT-Y, NUT-Y shows a significant increase in the bacteremia group compared to the normal subject. This difference was even further enhanced when we tried to differentiate the bacteremia from the septicemia group. So what we got from our ROC cutoffs using Uden's index was that for the two parameters which showed the maximum promises were NUT-Y and neutrophil lymphocyte ratio. NUT-Y had a diagnostic sensitivity of 1, which is 100%, and a specificity of 0.93. The positive predictive value was 0.9, and the negative predictive value was 1, and accuracy was 0.96. So NUT-Y was the most sensitive marker amongst all the markers that we studied to differentiate bacteremia from septicemia. Likewise, NLR had a diagnostic sensitivity of 0.86 and a specificity of 1 and a positive predictive value of 1 and accuracy of 0.92. So NLR was although less sensitive than NUT-Y, but was the most specific marker amongst all the markers available. So if you want to screen patient, NUT-Y is the better parameter than NLR, although it is not 100% specific, but it doesn't miss out anything. Whereas NLR cutoff was more specifically able to differentiate between bacteremia and septicemia. We also did study for the immature granulocytes. Although immature granulocytes was very good in differentiating normal patients from the bacteremia septicemia group, its sensitivity was 100%. But the problem was with its specificity, which was only 33.3%, which means it was not very able to differentiate the bacteremia from the septicemia group. The area under the curve was also 0.6, and the model had poor to fair discrimination. Hence, this cutoff was not clearly able to differentiate cases of bacteremia from septicemia. So our study showed some interesting results for differentiating bacteremia from early sepsis. Although we could not find a direct correlation between rising procalcitonin values with any of these subject parameters. So none of these parameters showed a similar increase with the rise in procalcitonin values, hence could not be used as a monitoring tool just like procal can be. However, both NUT-Y and NLR showed up strong utility in predicting of developing sepsis. The ROC cutoff for differentiating bacteremia and septicemia were 492.4 and 10.66 respectively for NUT-Y and NLR. So in conclusion, both NUT-Y and NLR are promising markers to differentiate bacteremia from early sepsis with high degree of accuracy. These markers can become a robust screening tool to diagnose early sepsis and can help reduce both morbidity and mortality. And although these markers are not reliable to predict severity of sepsis compared to procalcitonin, the search for a future marker is still on, where you could use a hematological marker in place of procalcitonin to use it as a monitoring tool. Next we have is the high fluorescence cells. As I earlier told you, these are large lymphocytes that contain a large amount of cytoplasm. Often there is a characteristically bluish tinge of cytoplasm and the cell averts. So this relative lymphocytosis is usually seen in viral illnesses, primarily infectious mononucleosis, hepatitis, cytomegalovirus, dengue infection, now also in the COVID infection. These can also be seen in drug and toxic reactions, immunization, radiations, hormonal causes, certain malignant diseases, idiopathic disorders, certain autoimmune disorders, and graft rejections. So this has got specific traction with dengue infection because it has been used as a prognostic marker in conjunction with the immature platelet fraction in predicting platelet recovery in dengue patients. Usually HFC increases on day 4 of dengue infection. The biological reference interval that we established in our lab for HFC was 0 to 0.4%. Increase in HFC correlates well with platelet recovery in dengue patients, and this can be used as a very useful prognostic marker in dengue along with IPF. It is also increased in other viral infections, but the value is seldom more than 5%. I'll just show you a case of dengue. Day on day, how HFC increases and then finally decreases, and its correlation with the platelet recovery. So this is a patient of dengue which is confirmed on NS1 antigen. This is day 1 of fever. if you look at the platelet count, it is 265. And if you look at the HFC, it is 0% on day 1. If you look at the WBC scattergram, this is the area here, just above the monocyte. There is hardly any dots here. Same patient, day 2, the platelet has gone down to 224. IPF is 0.6. The HFC is slightly increased to 0.1. You are able to see 1 or 2 dots in this scatter area. And still HFC is within the normal range and the platelet is also fine. This is stage 3, platelet 204, HFC 0.2. Again, you are seeing these 2 or 3 dots just above the monocyte. Come day 4, platelet is 161 and the HFC is now for the first time increased to 2.8. You can see in this corresponding scatter plot. Now you are seeing a significant amount of this green population, which is the HFC population. Day 5, platelet 121, HFC has gone up to 11.4. You can see the scatter area in the HFC is significantly increased. Day 6, platelet 126, HFC is at its peak, 23.5%. This scatter plot is even more dense. Day 7, this shows platelet recovery. Simultaneously, the HFC comes down to 10%. So a fall in HFC corresponds to an increase in platelet count in a case of dengue. So more important than even a fall in HFC, we are actually now looking at a jump in HFC. Whenever there is a 3 to 4 times jump in HFC from day to day or intraday, from that time we usually say that the platelet recovery is round the corner within 48 to 72 hours. So this is the study that we presented in ISLH last year in 2019 in Vancouver, where we clubbed all the prognostic markers of platelet recovery in, thrombocytopenic dengue patients, immature platelet fractions, platelet lymphocyte ratio, HFC, platelet HFC ratio, and we were trying to come up with what is the best prognostic marker amongst all these prognostic markers. So the objective of this study was again simple, that we were trying to look at which of the markers, after evaluating all of them, is the best marker for predicting platelet recovery in dengue thrombocytopenic patients, and which of these markers can be useful to clinicians in decision making over a defined period. So what we did was, we had 62 confirmed dengue NS1 antigen or IgM ELISA patients who had platelet count less than 1,50,000. These patients were filtered according to only those exhibiting both rising and falling trends of platelet and other predictive markers. So if a parameter did not have either both rising and falling trend, those patients were excluded from the study. The criteria for significant platelet recovery was an increase in platelet count by 10,000 or 10%, whichever is lower, over the preceding values. And predictive values were classified into peaks, troughs and falls. So the jumps were taken as at least 3 times jumps over the previous days, and falls were classified as decrease in 50% from the preceding value. So these are the parameters that we measured: MPV or the mean platelet volume, immature platelet fraction or IPF, high fluorescence IPF or HIPF, the high fluorescence cells or the HFC, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and platelet HFC ratio. For each of these parameters, we did also measure their peaks and their troughs, as well as for HFC we measured both peak and jump, and for platelet HFC ratio we measured both the trough as well as the fall. So these are the results. So you can see that basically the value which were delta values, the last one, are the most important column, and the 2 important parameters here were the PHR fall or the platelet HFC ratio fall, as well as the platelet HFC ratio, which shows the maximum sensitivity compared to the other parameters. So if you look at within 24 hours, the parameters which are peaked here are the ones which are least useful to us, which means that the neutrophil lymphocyte ratio and the mean platelet volume are of no use to us, because their increase is correlating with the actual recovery of the platelets. Rather, the ones which are lowest here, which is the PHR fall and the PHR in totality. These parameters are the ones which are most useful to us. So looking at the delta values, both PHR fall amongst the fall parameters and the HFC jump are showing good sensitivity. So this is the delta value. So amongst the fall jump parameter, PHR fall has a delta value of 71%, which is the highest. So what we established here was that platelet HFC ratio trough had a delta value of 52% and the platelet HFC ratio fall had a delta value of 72%. So when we combine the platelet decrease along with the HFC in the form of a platelet HFC ratio, the delta values get augmented and it gives the best sensitivity or the best prognostic marker to look for platelet recovery. Now, we are also looking at HFC very interestingly in COVID infection in 2020. HFC, according to a lot of Chinese data, has usually reduced in COVID infection. The neutrophil lymphocyte ratio is elevated and there is lymphopenia in the initial phase. Some of the studies have even given cutoff value of neutrophil lymphocyte ratio of about 3.13 to differentiate between mild from moderate to severe COVID infections. However, a subset of patients in our study showed mild increase in HFC after day 5. All these patients in our ongoing study, there were 128 patients, have shown either normal or decreased inflammatory markers, that is the neutrophil lymphocyte ratio, C-reactive protein, ferritin, interleukin 6 and LDH within 48 to 72 hours of the increase in the HFC values. So we believe that the increase in HFC values may be used as a predictive and prognostic marker in COVID infections to detect either mild disease or a recovery from illness. Both neutrophil lymphocyte ratio and HFC are probably the cheapest inflammatory markers in COVID infection and can be in places where they have not facilities for more sophisticated inflammatory markers to be tested. So with these words, I'd like to thank you all. And if there are any questions, I'll be glad to answer. Thank you.
Thank you so much, Dr. Pradeep Suri. Excited and learned a lot. Though I'm a clinician, but it was wonderful listening to you and the intricacies of the subject that you covered. So we have some of the faculty here. If they have any question, we'll first ask them till the audience put in some question in the question box. So Dr. Gayatri, Dr. Swati, Dr. Jyoti, if you all have any questions, please go ahead.
Sir, I have a question.
Yes. Tara, go ahead.
Dr. Suri, the NLR ratio we know is increased in bacterial sepsis, but in the COVID infections also we've been seeing this as an increased. So on what basis, I mean, only using these parameters in your studies, can we differentiate early between bacterial sepsis and COVID infection?
So, ma'am, when we did the sepsis study, this was done in late 2019, early 20, before the onset of COVID. So we have not particularly looked at sepsis in COVID patients, but our ROC cutoffs were different. So the ROC cutoffs for differentiating bacteremia from septicemia in the pre-COVID patients was 10.66. Whereas the differentiation of mild to moderate COVID infection, the Chinese cutoff is 3.13. But in our ongoing study, our cutoff is more like 3.6 between differentiating mild from moderate COVID infection.
Okay. Thank you.
Thank you. Dr.
Pradeep, can I ask?
Yes, sir.
I've been following your work since the ISLH time and on sepsis, bacteremia, NLR. But in keeping with the previous session, have you looked at monocytes and their cell population data, their width in various infections? Everybody is looking at neutrophils and lymphos. Have you looked at monos?
So ma'am, we were looking at both mono Z, mono X and mono Y also in our study. But we could not find any significant correlation, unlike the one that the MDW study is there on the Beckman analyzer. So what I realized was that what we are measuring in mono Z particularly, because monocyte Z is the one that is going to show the larger monocyte. The mono Z study was not giving us good correlation, primarily because our mono Z is more like the MCV of RBC, if I would like to make the same corollary, whereas their MDW is more like the RDW of RBC. So we do not have an equivalence parameter on our analyzer to assess the way the Beckman have done on their study.
No.
Thank you. Dr. Jyoti and Dr. Gayatri.
A very nice study, and Dr. Suri is always doing a lot of innovative work on his cell counters.
Just bring your mic closer to your mouth.
Cell counters and the urine analyzers. And as far as NLR is concerned, maybe it was more, it's more of a prognostic rather than a diagnostic issue in patients with COVID. But I think your HFC data may come in more handy in COVID. That's what I have a feeling. We've had almost 400 beds of COVID, and we have lots and lots of data of CBCs of the COVID. So maybe that would be maybe a better parameter rather than NLR, which is known to be a prognostic, and we did find it to be a prognostic marker. Like that's why people kept it as a marker to decide on admission of patients also.
Ma'am, I agree with you. I find HFC more useful, especially because a lot of these COVID patients have also been given corticosteroids. So once the corticosteroid is given to the patient, then the value of NLR goes for a 6, because all patients on corticosteroids are going to have high NLR. So I found HFC to be more useful. Yes, I agree with you on this point.
Thank you. Dr. Gayatri.
Very interesting, and thanks for sharing this information. I have one question that is beyond what you have shared with us today. There was always, initially, everybody mentioned leukopenia as one of the important parameters and the initial abnormality. Have you looked at that versus the your transformed lymphocytes and monocytes?
So, ma'am, patients with leukopenia generally are faring better than patients with increased TLC counts, is what my initial thing is. Barring those patients who develop leukopenia late in the development of sepsis in COVID patients, in the first week of infection, people who are coming with TLC counts of say 2,500 or 2,000 are generally faring better than the ones who are coming out with a count of 6, 7, 8,000.
Did you find any correlation between the leukopenia, the lymphocyte monocyte differential, and the COVID positivity? Did you actually find that?
So no, we did not look at COVID positivity. We are actually looking at the other way. We are now looking at these parameters in COVID positive patients. So these are already PCR confirmed COVID positive patients who are coming to us primarily to get their inflammatory markers checked. So we are not diagnosing COVID per se, but we are trying to look at when these markers, which of one of these would need admission. So what I've seen is that patients who have got lower NLR, less than about 3.5, 3.6, are the ones who are more likely to present with an HFC augmented response on day 5, day 6. And these are the patients who are likely to either be managed from home, or sometimes they are asymptomatic people who do not even develop fever.